I'm here with Farhad Hafezi. Farhad, you know, I'm excited about collagen cross-linking. I think it's going to be great. We're on the verge, I hope, of being able to use it in the U.S. and the context in which we're going to be using it is for keratoconus and ectatic problems. But you're using it in quite a different way. Can I get you to talk about that a little bit?
Hi Josh, thanks for having me here. Yes, what we are most excited about actually is the shift from the concept of cross-linking from a rare disease like ectatic disease to corneal infection, one of the major causes of global blindness. Why is cross-linking so versatile? Simply because it's not a technique per se, it's a physiological principle that was rediscovered and that can be used in various fields now.
Now, you brought some very nice slides. I'm eager to get a look at them, so let's get a look at them now.
Great.
Okay.
Infectious keratitis represents a new indication for corneal cross-linking. It is one of the global causes of blindness, with an estimated more than 5 million new cases in developing country, minor corneal trauma, little to no access to the healthcare system, brings a lot of eyes into legal blindness. We know the state of the art, which is medication, but we also know that sometimes we face major diagnostic and therapeutic dilemmas and difficulties, and sometimes eyes end up in catastrophes like the one you see on the left. Interestingly, the proof of concept of cross-linking as a therapeutic means was given by our group back in 2008. How does it work? First of all, this is the new definition of the term. We took a consensus at the last Cross-Linking Congress to call this pack-cxl, photoactivated chromophore for keratitis, to make a difference to conventional CXL for keratoconus. We assume that PAC works by 3 different mechanisms. On one hand, it can intercalate, so irreversibly bind with the DNA of the pathogen and stop replication. The huge load of oxidative stress that is generated kills many pathogens, and lastly, cross-linking per se changes the 3-dimensional structure of the collagen, making it harder for the collagenases to dock to the cleavage sites. The first study was performed in the lab in 2008. This was an IOV's paper showing that using the Dresden protocol settings, so 30 minutes, 3 milliwatts, you can kill a lot of MRSA and Staph aureus. In the same year, we published the first results in a case series of 5 patients having remarkable results in therapy-resistant corneal ulceration. And this is the most amazing case series that was published by a Swedish group. Here, no antibiotics were used at all. This is cross-linking only. Before
this is just cross-linking. There's
not a single drop of
antibiotics. That's fantastic.
So they received an ethical committee clearance that allowed us to really show the difference between the effect of pack-cxl, and this is what we are so enthusiastic about. Now, we took it into far advanced impending perforation ulcers. This was published just 2 months ago, and even in these very advanced cases it works. But the real challenge would be to apply this on a global level in early infiltrates and small ulcers. So to meet these unmet needs, we have to make this technology inexpensive, take it out of the operating theater, make it fast, make it small, make it secure, so we can give it into the hands of the general ophthalmologist. To do so, we are able, our own research now, push down accelerated the treatment to 2.5 minutes. We are able to kill 99.9% of MRSA, Candida, Pseudomonas in 150 seconds, and we are planning to get this device to market as a spin-off company from the University of Geneva. You take off the Goldman tonometer, you place it on the slit lamp, and so an eye doctor in a remote region with little infrastructure will always have a slit lamp, so he has an infrastructure to use cross-linking. There will be 2 heads to it, a keratoconus head and an infectious keratitis head with different irradiation profiles, and most importantly, a safety mechanism that measures the fluorescence of the chromophore in real time. This will not be riboflavin anymore. It will be a new chromophore that is more efficient. Measures the fluorescence and stops the surgeon if there is not enough fluorescence, or if the patient has moved the head away from the slit lamp. So by implementing all these safety measures and having a small device, we hope that every ophthalmologist will have the opportunity to treat a small ulcer as soon as it comes through the door of the private practice.
So that looked, obviously, that looked brilliant. Let me ask you, what do you think the time frame is for getting this device into practices?
We hope the time frame will be 12 to 18 months.
Oh, that's soon, really?
Yeah. Why? Because the wavelength is the same as is actually used in all the cross-linking devices. We will offer 3, 9, 18, and 30 milliwatts. And all these intensities are already on the market in other devices. The fluences are similar. The big difference in device is the safety mechanism, the possibility to have 2 different irradiation profiles in one machine. It will be very inexpensive. We want everybody to be able to afford the machine. So I think the first step will be rather fast, and then probably 12 to 18 months later we will launch the new Chromo4 that is even more efficient than riboflavin.
Can you talk about the Chromo4, or is that not something that we can talk about just yet?
For IP protection I cannot reveal the substance,
sure.
But it is a substance that is already in use in ophthalmology, so it's nothing that is new and has to go through major regulatory processes.
Right, that was what my question was, yeah.
But we found a new mechanism of action to a known substance.
Farhad, this is wonderful, wonderful stuff. I'm really grateful that you've shown it, and I'm especially grateful that you've been so generous with your time with us today.
Thank you, Josh, for spreading the word.